representing a 73-year-old man with a medical history of hypertension and elevated LDL cholesterol was admitted to the hospital due to non-ST segment elevation, myocardial infarction with high troponin levels. An echo revealed a normal left ventricular ejection fraction but showed inferior akinesia. The patient's treatment plan included dual antiplatelet therapy, atorvastatin, ezetimibe, and bisoprolol. An urgent coronary angiography was performed, revealed occlusion of the right coronary artery as the culprit vessel. After thromboaspiration, the artery was successfully revascularized using a 3.5 by 36 millimeters DES. However, there was a persistent thrombus image at the proximal edge of the stent, so the decision was made not to post-dilatate and check at a second procedure. Furthermore, two lesions were observed in the left anterior descending artery, one proximal and another in the distal mid-segment. We enrolled. This is the image of the right coronary artery.
Aquí la guía de presión, ¿vale?
And this is the LAD. The plan for today is to perform angioplastic guide by pressure wire and OCT in the anterior descending artery if necessary, and to conduct an intracoronary imaging examination of the stent in the right coronary artery.
We are going through a 6 French sheath in the radial artery, in the right radial. We have reviewed the previous stent we implanted a few days ago, and I will show you the images. We have reviewed angiographically. It seems to be okay. As you see, the artery is quite static. So the plan is this: the stent. I am going to advance you some information. The stent with OCT was quite malapposed, especially in the proximal part. You can see in the angio that there is an aneurysmatic zone in the mid part of the stent. And this one obviously is malapposed, and also the proximal part. So we decided not to post-dilate in the previous procedure because the thrombus burden was quite high, and in order to reduce the no reflow phenomena.
You can see here it's a long stent. The distal border is okay. And in the proximal part, there is an artery aneurysm with a diameter of more than 6 millimeters. And the proximal part of the stent seem to be okay, seem to be good apposed. So we have dilate with a compliant balloon. So Alfonso, if you want to continue.
Yeah, a 4.5 balloon just to oppose this proximal part, because this mid part of 6.5 millimeters in diameter, it's impossible to oppose. So we have post-dilated with 4.5. We have a little bit of problems to enter with the 4.5, so we have used a conqueror balloon just to dilate a little bit the entrance of the stent. That was the strut was there was in a bad position. We're in a bad position, and after the conqueror, we post-dilated with a 4.5, expand the struts that were in a bad position there. So this is the result after the post-dilatation. This one that is quite good. So we are moving to the left artery. You can see this diffusely. This is LAD with severe angiographically severe lesion in the mid-distal part. We're going to advance the pressure wire distally to this lesion. There are some disease in the proximal part, so we have to interpret the results. Patient sometimes does funny atrial arrhythmias without a wire there. Test, please. Okay, I am selectively in the LAD, probably. Okay. We're going to equalize. Okay, done. So in this study, you need to perform FFR. We are doing also RFR just for curiosity. So we have advanced the wire distal to this lesion. Salino, por favor. So we're going to wait a little bit to measure the RFR. You can bet, but probably it's going to be positive. And the study, the trial said if the pressure wire is positive, you under FFR under 0.75, you have to treat it, of course. And if not, we perform OCT to interrogate if the lesion has a vulnerable plaque there. So we are administering adenosine here, intracoronary adenosine. Let's see the ECG. Okay. Okay, I have administered almost 300 micrograms of adenosine. Medimos. Okay, 0.72. We can review the, but I think it's quite stable, the pressure there. We can put again RFR just to see the pullback, but I think we have to treat this lesion, right? Okay. So RFR, I'm going to retrieve the wire here to check the pullback. 0.86 here, that was the initial RFR. And now here is a big jump proximal to the lesion that was angiographically severe. And here the RFR is 0.94, 93. So I think it's obvious that the proximal part is not functionally severe. So I'm going to advance again the wire and probably treat the distal part. Okay, so we are not doing more measurements. We're going to predilate this lesion through this wire. So in this study, if we measure an FFR under 0.75, we have to treat the lesion and then optimize with OCT. So we are predilating the lesion, and then we will check switch again to the OCT mode to confirm the result of the stent. Yes, this is the pressure wire of Abbott. That is the conventional one.
No tiene a mí.
Okay, let's go. Le pusimos más heparina, ¿verdad? Hace un rato. Test, por favor. All there, ¿no, Santi?
Yeah.
Venga, dale. 12, ¿vale? I think it's enough. I'm going to retrieve the balloon. Test, please. Okay, I think it's enough. You can use this wire for the PCI, probably. Conventional workhorse wire could work a little bit better through these carbs of the distal vessel, but I think we have enough support to advance a stent. Give me some nitro. Let's do another angio after nitroglycerin. 2 more. Okay, contrast. Okay, fine. Okay. Give me a stent 2.5, 18 or 20. The balloon was 15, right? So we're going to implant a science 2.5 by 18. The balloon was 15 in length. So I think that we are going to cover the focal severe lesion that we have seen the jump in the FFR, in the RFR measurement. So this trial and also the vulnerable trial that we are involved in are going to explain some interesting points in this non-culprit vulnerable plaques or not vulnerable plaques. Yes, por favor. I think I'm almost there. Tess. Ok, ábrelo. Nominado, We are going up to nominal pressure as the vessel is quite diseased.
As there are no questions,
Juan tampoco.
as you have in place a pressure wire, would you be confident if the result of the pressure wire normalize after stent implantation, or do you prefer guiding with intracoronary imaging?
It's a very good question. There are some trials about the optimizing of the stents with pressure wire, but the results are not. When you do FFR or IFR or RFR after a stent, you always feel you have done something bad because the result is not one, never. And there are some trials explaining that if you optimize with post-dilatation and these things, probably you improve a little bit the measurement. But I feel more comfortable analyzing with imaging after the stent than with functional tests. The question was prepared just to introduce the OCT analysis. It was quite reassuring that the measurement, the RFR, was negative just for the proximal part of the vessel that was a little bit diseased. We are using the same pressure wire to advance the OCT catheter. ¿Tienes guía? ¿Tienes Ali? Sí. I don't have a lot of distal vessel to advance the OCT catheter. Let's see if we can advance the lens distal to the stent.
A little bit more.
A little bit more.
You are there.
Probably there. Okay.
This is the distal border.
Okay. Let's continuar. Sí. Inyectamos. Okay. Sacamos. It was just in the distal edge of the stent, but we don't want to hurt anything with the wire distally. So Santiago is going to analyze with Maria the images. It's a branch.
Side branch with a small amount of thrombus seems to be here. But probably it's a remnant of the pre-dilatation of the lesion. There is some calcium outside of the stent, but the expansion is good. There's a mild malapposition in the proximal border, but it's very, very limited. I think it's not necessary to post-dilate. It's your decision. Between 2.5, 2.9.
Maybe 2.75, a short one in the proximal part. Okay.
Yep.
Let's do this. Dame un NC 275.8 tenemos. We're going to post-dilate the proximal part. I am going to try to advance another wire here because this wire is not doing these curves at the distal part, and I want to be safe there.
Probably we could talk about the post-dilatation of these findings of stents. Minor malapposition is necessary to treat. In my opinion, in the majority of cases, there is no necessary. But when you look, this finding is difficult to resist to treat.
Yeah, especially in the proximal part, right?
So
as you have seen, I have advanced cyan blue to the distal part of the vessel. It's quite safer now because I think we have to recheck with the OCT after the post-dilatation. To retrieve this one a little bit. And then I'm going to advance again this wire, just the proximal part of the stent. No?
The mid and proximal is not the proximal border is near the proximal border, but a few millimeters
probably
inside
there.
the stent. Probably there.
Okay. Arriba. A 12. Okay. Down. Okay, dale. Okay, can we switch to the FFR mode just for curiosity to check the result after this optimization? I'm going to advance again the pressure wire, if I can. Okay, there. I'm going to reconnect the wire. So we are doing RFR. The initial measurement was 0.86, if I remember well. We are waiting a little bit more because we have flash with saline, but probably is in the threshold. It's a little bit better than the initial measurement in the threshold or RFR. We are doing FFR again with adenosine, just to show you the discussion we have had before, Santiago and me. And then we will do the OCT.
And what do you think, Alfonso, about when you treat probably lipid-rich plaques, and after stent you induce some distal embolization? How can affect this the measurement of functional parameters?
Probably, dale María cuando quieras. Probably this is the reason of having these results after optimal stent implantation. Probably the distal embolization of the distal repercussion in the microcirculation is doing is responsible for this result. So here the FFR, okay, detener, is 0.79, 0.80. The initial one was 0.72. Is better, but the result is there. Probably there's something in the microcirculation in the distal vessel that is producing this. So we are retrieving this wire, the pressure wire, and performing the final OCT with the CM. Okay. Okay. Santiago is saying that we are doing the long pullback now, just to check not only the stent but also the proximal part of the vessel that is diseased. Okay. And do this combine intervene, a really combine intervene, because the proximal part is functionally not significant, but we have the possibility to interrogate as well with the OCT. I think I am now in the distal part. Okay.
You can see how the malposition has improved, has been corrected, but in the proximal part of the stent, there is some moderate fibrous-rich plaque, and there's some lipid-rich tissue. Probably this zone is based on macrophages, as you can see here, and there is a plaque with a thick fibrous cap. This is not the objective of the combined intervention study. This is not a thin cap fibroateroma. It's a thick cap. You can see some cholesterol crystals inside
Estamos terminando, ¿vale? Va todo muy bien.
Inside the plaque. You can see here another lipid-rich plaque. Again, there are macrophages inside with a dorsal shadowing.
The distal part of the stent is also okay,
Yeah,
Santi?
I show you. The distal part was we see previously, and we have not touched there, but you can see here there is no dissection.
Okay, because in the angio is a small plaque there, but I think
maybe that have some spasm. I think
okay.
there is no dissection in this point.
Okay.
And in the proximal part, you can see the malposition is practically corrected.
So I think we have not to treat the proximal part. The distal part has been integrated with functional tests and also with OCT. The stent is okay, so we are finishing the case. I'm retrieving the wire. I have done also an angio after that. That is okay. So we are finishing the case and see you in future cases. Thank you.